We'll start out with the Healthy People 2030 objectives and nursing significance. One of the goals is to reduce preterm births, which will help focus attention on the need for close antepartum surveillance and identification of risk factors for preterm labor or births, and provide appropriate interventions to reduce it. The second goal is to reduce cesarean births among low-risk women with no prior births, which will reduce the number of surgical births with accompanying risk factors, which are very high, and costs, which are very high, by appropriate labor management, continual labor support, and practice patterns. Risk factors for dystocia, or also called failure to progress. Dystocia is the abnormal progression of labor characterized by slow and abnormal progression. It is the leading indicator for a C-section, and it basically includes the lack of progression of cervical dilation, lack of descent of the fetal head, or both. The issue is that 1 in 3 women will give birth by C-section because of dystocia. Normal labor will start with regular uterine contractions that are strong enough to result in that cervical effacement and dilation, which will, of course, allow that natural progression of birth. Now, if you think about it, all these risk factors will basically make the body fail to progress into that normal birthing ability. So epidural analgesia, excessive analgesia, that slows everything down. It slows down the contractions, it slows down cervical dilation, it makes it so that mom doesn't have the ability to feel when to push. Also, multiple gestation, hydramnios, if there's too much water for the baby to descend, and that descension with the head pushing against the cervix helps for the cervix to dilate, and of course, if there's too much water, that's not going to happen. Also, maternal exhaustion. She's exhausted. It's hard for her to push to get that down, to get the baby down into the canal. So those are just some different risk factors for mom to progress into natural labor. So there's different causes of dystocia. Problems with powers, so that's that uterine activity. So these are contraction patterns that prevent normal progress of cervical dilation, effacement, or descent. So hypertonic, hyper meaning a lot. This happens when the uterus does not fully relax between those contractions. Those contractions involve only a small portion of the uterus, and there's usually more than one uterine pacemaker sending signals for that contraction. Mom is often anxious. You will see painful, frequent uterine contractions that are ineffective. Usually occurs when mom is less than 4 centimeters along. The uterine contractions are uncoordinated. The cervix usually stays at 2 to 3 centimeters and does not dilate as they should. The force of the contraction may be in the midsection rather than the fundus, and as it's supposed to be in the fundus where that contraction pushes down. Those muscle fibers will push down. That uterus is unable to apply that downward pressure to push that presenting part against the cervix. So again, the uterus doesn't relax. She's going to have erratic, frequent contractions, She's probably going to be exhausted. Usually treated with therapeutic rest, warm bath or shower, analgesics, a lot of times morphine that will inhibit those contractions and hopefully reduce her pain enough to let her sleep. Also, Ambien has been given to help her rest. After 4 to 6 hours of rest, mom is likely to awaken in active labor with a normal labor pattern. So as the nurse, you're going to assess for CPD, or cephalopelvic disproportion. That's when the baby's head is too large to fit through that pelvis. Also, you're going to assess the fetal heart rate pattern, make sure there's nothing going on with the baby. Also, adequately hydrate mom. Now, hypotonic, this is secondary uterine inertia. It is the most common dysfunction, usually happening after she has dilated more than 5 to 6. Initially makes normal progress, but then the uterine contractions become weak and efficient, or they will stop altogether. The uterus is easily indented, and during the contractions, it's insufficient to efface and dilate. CPD, or the cephalopelvic disproportion and malposition, are common causes. Also, overstretching of that uterus. Large fetus, if there's multiple fetuses, also excessive use of analgesia. So they're going to have decreased frequency of contractions, or none, decreased intensity and briefer, and below normal resting tone. So basically that uterus will relax too much between contractions. Mom will probably be exhausted, yet again. She's also at increased risk for infection, also at increased risk for hemorrhage, because that uterus cannot contract effectively to compress those blood vessels. Treatment is usually, you're going to see mom have an ultrasound to make sure that to rule out cephalopelvic disproportion. Also assessing the fetal heart rate and pattern, assessing for infection, if there's any odd or abnormal characteristics of the amniotic fluid, if there has been rupture of membranes. If findings are normal without ultrasound, then labor augmentation is used, so making mom walk, ambulation, hydrotherapy, making sure there's plenty of fluid, artificial rupture of membranes, nipple stimulation, and oxytocin or pitocin infusion. Also, there's other terms, protracted and arrest disorders. Protracted is slower than normal rate of descent, and arrest is complete cessation of progress. Now, precipitate labor is labor that lasts less than 3 hours from onset of contractions to the time of birth. It occurs in approximately 2% of all births. The precipitous birth alone is not usually associated with significant maternal or infant morbidity or mortality, but it can absolutely result in maternal injury, also fetal asphyxia or trauma. So if you think about it, that baby is not getting mashed. All that fluid is not, it's going to be staying in those lungs. So absolutely there can be problems. Causes may result from a hypertonic uterine contraction that are tetanic. Maternal perineal tissues stretch readily, permitting that fetus to pass through the pelvis quickly. Also, conditions associated with this type of pattern include placental abruption, which is never a good thing, excessive number of contractions, and also recent cocaine use. Don't use cocaine. Complications, uterine rupture, lacerations of the birth canal because that baby's going through really quick. Postpartum hemorrhage, also for the baby, hypoxia can be caused by decreased periods of that uterine relaxation between the contractions. Also, intracranial trauma can happen, injury, hemorrhage, nerve damage related to that rapid birth. She may actually need tocolytics to slow the labor. So magnesium, indomethacin, terbutaline, nifedipine may be given. Also, the maternal pushing powers can be compromised when large amounts of analgesia are given. It may block that bearing down reflex and alter the effectiveness of her bearing down efforts. She will be exhausted. She will have lack of sleep, long labor, fatigue from inadequate hydration and food intake. Also, maternal position can work against the forces of gravity and decrease the strength and efficiency of those contractions. Also, alterations in pelvic structure. So pelvic dystocia can occur when there are contractures of the pelvic diameters that reduce the capacity of the bony pelvis, including the inlet, mid-pelvis, outlet, or combination. It can also be caused by congenital abnormalities, maternal malnutrition, neoplasms, or lower spinal disorders. Pelvic deformities may also be a result of a motor vehicle accident or other accidents that cause trauma. Also, obstructions in the maternal birth canal can be soft tissue, basically anything that does not involve the bony pelvis. There can be fibroids, a full bladder or a rectum can prevent the fetus from entering the pelvis. An STI, such as HPV, can alter that cervical tissue integrity, and it can interfere with adequate effacement and dilation. You can also have problems with the passenger, so the baby. It can be caused by structural abnormalities if the baby is big, malpresentation, especially with breech presentation, malposition, the occiput posterior position, or multifetal pregnancy. If the head is poorly flexed, if there's poor uterine contractions, any position other than the occiput anterior is not a good position for baby to be in. Complications can be neonatal asphyxia, fetal injuries or fractures, and also maternal vaginal lacerations. Although a spontaneous vaginal birth is possible, a lot of times it's necessary to assist that birth with forceps or the vacuum or possibly a C-section. So malposition, occiput posterior position is the most common. It occurs in approximately 15%, and about 5% are in this position at birth. Labor is prolonged. There will be possible extensive caput succedaneum and molding of the head due to that position. Again, you're going to anticipate possible use of forceps to rotate to the anterior position at birth. Now, mom is going to be typically complaining of severe back pain. That is from the pressure of the back of the head, the occiput, against her sacrum and coccyx. So make sure that you are doing measures to relieve that back pain, encourage the rotation of the fetal occiput to the anterior position. You can use low back counter pressure. Also hands and knees positioning, rocking that pelvis back and forth. Side lying position, side lunges during contractions, sitting, kneeling, or standing while leaning forward. Squatting. The squatting position also will give the pelvic outlet room to enlarge, helping that fetal head rotate. Also, you can do lateral abdominal stroking in the direction that the fetal head should rotate. Stair climbing, making sure they're in the Sims position on the same side as the fetal spine as much as possible during labor. But all those things can happen, but the most important thing is to take care of mom's pain, because she's not going to be able to do all these positions if you're not treating her pain effectively. Malpresentation, usually by week 35 or 36, most of the babies will spontaneously settle into the vertex presentation, so the head will be first. But sometimes that doesn't happen. Breech is the most common form, with the butt and the feet presenting. It is associated with multifetal gestation, preterm birth, if there's any anomalies of mom or baby. The diagnosis is usually made by abdominal palpation, Leopold maneuvers, and vaginal exam, usually confirmed by ultrasound. During labor, breech presentation may slow because it's not as effective dilating wedge. So that labor can be prolonged because that butt is not hard enough to effectively efface and dilate that cervix. And there's also a risk of a prolapsed cord if there is rupture of membranes early in labor. Vaginal birth is accomplished by mechanisms of labor that manipulate those buttocks and lower extremities as they emerge, done by the healthcare provider, clearly. External cephalic version, ECV, may be tried. And if it is unsuccessful, they will usually have to have a C-section. The C-section is indicated if the presentation persists, if there's fetal distress that occurs, or if the labor stops progressing. A C-section is necessary for a transverse lie, though the ECV can be attempted after 36 to 37 weeks. And with mom doing an ECV, basically, and I've got a video that you can watch that's in your PowerPoint, but most of the time when they do an external cephalic version, they're going to be given a tocolytic to make sure that they do not have contractions while the healthcare provider is manipulating the baby, and it's very painful. So you might have moms be like, stop, you can't continue doing this. And a lot of times ended up the baby is going to have to be born by C-section anyway. And a lot of your healthcare providers are going to be doing a C-section regardless if they're breech. So maternal pregnancy, so twins, triplets, or more, that's within a single pregnancy. This accounts for 4% of all live births. It is increasing in number, attributed to the use of fertility enhancing meds and procedures. Also advancing maternal age. Moms usually will go into labor before 37 weeks. It is associated with a lot more complications, a higher incidence of fetal newborn complications, and higher risk of perinatal mortality, primarily from low birth weight infants due to preterm or intrauterine growth restriction, both, whatever. The fetuses can experience distress and asphyxia during the birth process because there might be a cord prolapse. There may be an onset of placental separation with the birth of the first fetus, which will cause poor perfusion to the second fetus. Always a risk for long-term problems such as cerebral palsy. A patient is at increased risk for hypertension, anemia, and hemorrhage associated with uterine atony, placental abruption. Also, teamwork and planning are essential components when you have a mom with twins or triplets or higher. Each infant, hopefully, will have its own team of healthcare providers present for birth, and a C-section is almost always performed by the healthcare provider when there is a multifetal pregnancy. Macrosomia is when the newborn weighs 4,000 to 4,500 grams. That's 8.13 to 9.15 pounds or more at birth. It complicates approximately 10% of all pregnancies. It's also associated with later in life obesity, diabetes, cardiovascular disease, hydrocephalus, ascites. Mom is also at risk for postpartum hemorrhage, baby shoulder dystocia, low APGAR scores, of course, dysfunctional labor, soft tissue lacerations during a vaginal birth, and perinatal asphyxia. Now, cephalopelvic disproportion, again, that is basically when the size of the fetus and the size of the pelvis is not, the baby cannot fit through it. It can't be predicted accurately. Usually it's related to macrosomia when the baby is a lot bigger. It's also associated with diabetes. It also may be caused by the malposition of the presenting part. So if that pelvis is too small or abnormally shaped or deformed for some reason, it can happen. So that disproportion usually ends up being a C-section. There might be a trial of labor if mom is adamant, but most of the time it's going to be a C-section. Now, other causes of dystocia, so maternal positioning, basically the position needs of mom can provide a mechanical advantage or a disadvantage to the mechanisms of labor. So gravity can help. Lateral position facilitates the rotation. Upright positions can enhance that fetal descent during pushing efforts. And when you discourage mom's movement or restricts her to the recumbent or lithotomy position, it can compromise progress. So always encourage movement of mom. Now, also psychologic responses, hormones and neurotransmitters that are released in response to the stress of labor can cause dysfunctional labor. Also, confinement to bed and restriction of movement, that can be a source of psychological stress, compounding that physiological stress. And when anxiety and depression is excessive, it can inhibit cervical dilation. Anxiety causes increased levels of stress-related hormones such as beta endorphin, adrenocorticotropic hormone, cortisol, and epinephrine. These act on uterine smooth muscles and reduce contractility. Shoulder dystocia is the obstruction of fetal descent and birth by the axis of the fetal shoulders after the fetal head has been delivered. So that head's been delivered, but then that shoulder gets caught on the pubic symphysis bone. There is an increasing in occurrences due to increasing birth weight. It occurs in about 1 in every 200 births, or 3%. Usually results in approximately 5,000 new permanent brachial plexus palsy cases per year. It is a labor emergency. There's no reliable way to predict it. You know, the baby's in there. We don't know if it's going to get caught on that or not. Complications, of course, postpartum hemorrhage, vaginal lacerations, anal tears, uterine rupture for mom. Basically, there's 4 standards of care that all labor and delivery teams should be familiar with when caring for a mom that may experience shoulder dystocia. So the entire labor and delivery staff should know what to do and what each person's role is when shoulder dystocia is diagnosed. Again, it is an emergency. Labor and delivery nurses should know how and when to initiate the McRoberts maneuver, which I'll show you in the next slide, and when to apply suprapubic pressure. These measures often resolve the dystocia by flattening the sacrum and altering the angle between the pubic bone and the baby's anterior shoulder. The team should immediately obtain the assistance of another obstetrician, a pediatrician, and an anesthesiologist. Essential emergency measures for managing that shoulder dystocia: of course, oxygen, making sure that mom and baby have plenty of oxygen, patent IV access for mom for rapid fluid or blood administration, and of course fetal heart rate monitoring to make sure that baby does not go into fetal distress. Now, this is the McRoberts position. Basically, it's that sharpening of the hips, the flexion of the hips towards the shoulders. It's extremely effective, and it basically increases the diameter of the pelvis. It is often the only maneuver needed to resolve that shoulder dystocia. Basically, 2 assistants are needed to do this maneuver. They're going to hyperextend the mother's legs onto her abdomen. That movement will flatten the sacrum, changes that angle of the symphysis pubis in relation to the baby's anterior shoulder, usually freeing that shoulder. Basically, again, you're just sharply making that hip flex towards the shoulders. Also, suprapubic pressure is done to help with this. So when you basically place direct pressure with an open hand or fist just above that mom's symphysis pubis, that pressure can be directed straight down or to the left or right, whichever is directed. Basically, the aim is that pressure is going to help push that baby's shoulder out of the position behind the mother's pubic bone. It's always going to be suprapubic pressure. It's never going to be fundal pressure. It's never going to be up above, because you can cause a placental abruption. Never a good thing to do. As the nurse, you are going to assess the history of risk factors. So if mom is short or maternal short stature, if she's obese, hydramnios, uterine abnormalities, all these different risk factors you need to be assessing and hopefully knowing before we're going into labor. Also, maternal frame of mind, if she is having fear, anxiety, stress, if there's lack of support, if there's pain. You're going to assess the uterine contractions for frequency and intensity, the fetal heart rate, fetal position, reporting any abnormals. And you're going to have to be patient, because dystocia is diagnosed after labor has progressed for a time, not at the beginning of labor. Basically, there's a simple rule that mom should be progressing at least 1 centimeter per hour. Also, you're going to encourage her to empty her bladder often, which will help give that baby room, the head room, to push on that cervix and dilate and efface it. Now, preterm labor, basically the cervical changes and uterine contractions occurring between 20 and 37 weeks gestation. Basically, a preterm birth is anything that occurs before the completion of 37 weeks of pregnancy. It's the leading cause of infant death. It's basically, it happens in about 1 in 10 births in the USA. African American clients experience almost twice the rate of preterm labor compared to any other demographic groups. There's a risk for respiratory distress syndrome, infections, congenital heart defects, thermoregulation problems because of the immaturity. Also intraventricular hemorrhage, jaundice, all the things. A recent study found that a single course of corticosteroids prenatally improved most neonates' neurodevelopmental outcomes if it's given before 34 weeks gestation. Tocolytics, again, these are drugs that will help to stop labor. There are no clear first-line drugs to manage the preterm labor, but the goal is to prolong pregnancy for 2 to 7 days so that those steroids can be given for the fetal lung maturity, and that usually takes at least 48 hours to kick in. The tocolytic therapy is most likely ordered if the preterm labor occurs before the 34th week. Contraindications of tocolytic therapy is placental abruption, if there is fetal distress, oligohydramnios, eclampsia, active vaginal bleeding, dilation of more than 6 centimeters, chorioamnionitis. So medications that are given: magnesium, indomethacin, atosabin, nifedipine. Also antibiotic prophylaxis with women with group B strep. And then making sure that we are promoting that fetal lung maturity with the glucocorticoids, usually given to mom IM. It's considered one of the most effective and cost-efficient interventions for preventing morbidity and mortality associated with that preterm labor. So when you go into labor and the baby is not basically mature enough, those lungs aren't mature, there's not enough surfactant, there's not all the things. Our goal is to keep that baby inside as long as we possibly can so that the placenta can mature that baby. And again, those tocolytic drugs can help, but it's not always going to work. Major risk factors of preterm labor, again, African American race. If there's maternal age extremes, so very, very young or advancing maternal age, low socioeconomic status, alcohol or other drug use, especially cocaine, if mom has had poor nutrition or periodontal disease, if mom has smoked, low-level education, if there is a history of previous spontaneous preterm births, low pre-pregnancy weight, pre-existing diabetes or hypertension, premature rupture of membranes, if there's a short cervical length, clearly STIs, gestational hypertension, maternal anemia. Also, intimate partner violence can increase that risk. Infection is the only factor definitely shown to cause preterm labor. When bacterial, cervical, or a urinary tract infection, if that's present, the risk increases. So making sure early, continuous, and comprehensive prenatal care is essential for prevention of preterm labor. Prevention is the biggest thing you are going to be educating on: smoking cessation, making sure there are no drug use, alcohol use, all the things. You're going to ask mom about subtle signs that can indicate that she's going into preterm labor, such as if there's a change or increase in vaginal discharge, if there's mucus, water, or blood in it, if she is feeling pelvic pressure or a pushing down sensation, if she has a low, dull backache, menstrual-like cramps, feeling of pelvic pressure or fullness, GI upset, general sense of discomfort or unease, if there's a heaviness or an aching in her thighs, if she's having uterine contractions with or without pain, more than 6 contractions per hour, And contractions must be persistent, such that 4 contractions occur every 20 minutes or 8 contractions in 1 hour. Now, labs and diagnostic testing, you will see a CBC to detect infection, urinalysis to, again, detect a urinary tract infection, amniotic fluid analysis, that's just to determine fetal lung maturity, fetal fibronectin, and cervical length. The fetal fibronectin is a biochemical marker. It is a glycoprotein glue found in plasma and produced during fetal life. And it's found in between the chorion and the decidua, which is the fetal membranes, and the uterus. It basically attaches that fetal sac to the uterine lining. Now, the test is a useful marker if the impending membrane rupture is going to happen within 7 to 14 days. Basically, they will do a vaginal swab without lubricants. Mom can't have had sex as well. It usually appears in cervical and vaginal secretions early in pregnancy and then again in late pregnancy. It is helpful to determine preterm labor in moms that are either between 24 and 34 weeks. Before 24 weeks. Presence is not very sensitive as a predictor, but it can actually predict preterm birth in about 25%. Cervical length is a possible predictor of preterm birth, so if that length is greater than 3 centimeters, they are unlikely to give birth prematurely, even if they have symptoms. So that is definitely a good one to be looking at. If they have a short cervix, which is less than 3, combined with a positive fetal fibronectin, that risk of spontaneous preterm labor is higher. So tocolytic therapy will be given. Hopefully these are drugs that cause relaxation of the uterus, inhibiting those uterine contractions. The primary goal is to arrest labor and delay birth for up to 48 hours. May be used when other interventions have no effect, such as position changes, all those things. It may also be used to prevent uterine contractions before a C-section is done. The most common used tocolytic is breathine or terbutaline. It's given sub-Q. It works quickly. It also has been demonstrated to improve APGAR scores. Now, also, of course, the glucocorticoids are given before 34 weeks gestation to make sure that that baby's lungs are mature. Also, medications, mag sulfate. It is also one of the more commonly used. It promotes relaxation of smooth muscle by competing with calcium in the cells. It is administered IV piggyback. May be a good choice if other medications are contraindicated. There needs to be calcium gluconate next to the bed just in case mom experiences magnesium toxicity. You're going to monitor for nausea, vomiting, headache, weakness, hypotension, and cardiopulmonary arrest. If she has too much magnesium, if she experiences magnesium toxicity, it literally can cause respiratory cessation. So we definitely need to keep that calcium gluconate at the bedside. Terbutaline, again, these should not be used in patients with known or suspected heart disease, severe eclampsia, pregestation or gestational diabetes, hyperthyroidism, or headaches. They have many maternal and fetal adverse reactions. It can cause tachycardia and also hyperglycemia. That's the beta-2 adrenergic agonist. The They work by relaxing uterine smooth muscle as a result of stimulation of beta 2 receptors in the uterus. Nifedipine is a calcium channel blocker. It can suppress uterine contractions by inhibiting the calcium from entering uterine smooth muscle cells. Usually used to treat hypertension, angina, and arrhythmias, but also promote uterine relaxation. Of course, decreasing those calcium ions from going into the myometrium cells. It's given PO or sublingually every 4 to 8 hours. Signs, side effects of this medication: headache, flushing, dizziness, or nausea. For the baby, safety is usually achieved following recommended dosages, but it should not be given along with or immediately following a beta 2 adrenergic agonist. Also, indomethacin is an NSAID. It's been shown to suppress preterm labor, blocking the production of prostaglandins. This is limited to short duration if the patient's lower than 32 weeks gestation. Potential adverse effects: palpitation, shortness of breath. Those are the things that you need to be looking for with these beta 2 adrenergic agonists. Now, primary prevention is the goal. So you're going to educate mom on avoiding traveling long distances, avoiding lifting heavy objects, hard physical work. She can actually have a little bit of mild to moderate exercise. She also needs to wait at least 18 months between pregnancies, making sure she gets enough iron, visit the dentist early to evaluate any periodontal disease. If she's symptomatic, she needs to make sure she is not having sexual activity until after 37 weeks, making sure she is avoiding illegal substances. Her activity may be restricted to bed rest. Again, sexual activity. Those that are high risk are usually told to take it easy at home for weeks or months, which can be a challenge, especially with moms of more babies than just this one. And also, you can educate her to have frequent small meals, activities, limited naps, hygiene and grooming with assistance to maintain the control. Post-term labor is one that extends beyond the end of 42 weeks of gestation or 294 days from the first day of the last menstrual period. A lot of times these are not diagnosed effectively because moms cannot remember when the actual first day of her last menstrual period was. So a lot of times it's hard to tell exactly what the exact gestation is. Ultrasound is the best way to know that gestation is correct. Cause of post-term labor is unknown. It's more common in moms that have not actually had a baby. Also, it increases in those who have had previous post-term babies. Maternal risks, risk for hemorrhage and infection is higher in mom. Also, they're more likely to have interventions such as induction of labor, operative assisted birth, or cesarean birth. She may experience fatigue, physical discomfort. Basically, the placenta is aging, so that perfusion is decreasing. So for the infant, definitely increased risk for abnormal fetal growth, risk for small for gestational age. Macrosomia occurs more often as the placenta continues to supply nutrients to support that fetal growth. So the longer that they're in there, the bigger they're probably going to be. However, they may not be as healthy because of that placenta, the placental age being greater than 42 weeks. Decreased oxygenation to the fetus. After 33 to 34 weeks, that placenta begins to age. There's enlarging areas of infarction and increased deposition of calcium and fibrin, which will decrease that placenta's reserve. You may see meconium-stained amniotic fluid, which they will have an increased chance of meconium aspiration. You might see low APGAR scores in these babies. Also, post-maturity syndrome, which is characterized by dry, cracked, peeling skin, long nails, meconium staining of the skin, nails and cord, and perhaps loss of sub-Q fat and muscle mass. So as the nurse, you are going to assess the estimated date of birth, usually best with, again, the ultrasound. Neonatal morbidity and mortality will increase after 42 weeks. So pregnancy is usually not allowed to continue past this time. Most will be induced at 41 weeks. The patient is encouraged to assess fetal activity daily during that post-term period, assess for signs of labor, and to keep all appointments. During the labor, the fetus must be electronically monitored continuously for more accurate assessment of that fetal heart rate and pattern. And they may end up having to have an amnio infusion to maintain the cushioning of the cord. So they may have fluid actually inside. So labor induction is stimulating contractions via medical or surgical means. Augmentation is enhancing the ineffective contractions after the labor has begun. It may be electively or for indicated reasons. The rate of this has doubled to approximately 20% of all births. It may increase the risk for C-section, especially in primiparas and over the age of 35. Many of these elective inductions are purely for the convenience of the patient. So if she wants to deliver on a certain day, or if she wants to deliver before her healthcare provider is out of town, such as that. But again, the major risks are increased rates of C-section. It should not be initiated before 39 weeks gestation. Now, for indication induction, if continuing the pregnancy is dangerous for the patient or the fetus, or if there's no contraindications, then the amniotomy or augmentation is done with oxytocin. The patient has to be fully counseled regarding the risks, benefits, and alternatives of labor stimulation methods. Success rates are higher when the condition of the cervix is favorable or inducible. Now, cervical ripeness is the most important predictor of a successful induction. That's done by a Bishop score. This is a rating scale used to evaluate the inducibility of the cervix. It's a 13-point scale. So when the score is greater than or equal to 8, an induction is usually successful. With an 8 or greater on that scale, that indicates that the cervix is soft, anterior, greater than 50% effaced, and greater or equal to 2 centimeters dilated. And the presenting part is engaged. So before any kind of methods are used to ripen the cervix, that Bishop score needs to be documented. Cervical ripening is a process by which the cervix softens via the breakdown of collagen, leading to dilation. If ripe, the cervix will be shortened, centered, anterior, softened, and partially dilated. If it's unripe, it's going to be long, closed, posterior, and firm. Now that score, the Bishop score, will assess cervical ripeness. If it's less than 6, it usually indicates that a cervical ripening method should be used prior to induction. So alternative methods: blue cohash and mineral oil, black cohash and evening primrose oil, acupuncture, castor oil, hot baths, enemas. All this has not been evaluated scientifically. It's just some of the things that are natural labor inducing. Physical methods such as sex, so the prostaglandins in semen, and stimulation of uterine contractions with orgasms. There's actually no adequate evidence that an orgasm enhances cervical ripening. However, who's going to say no to an orgasm? No one. Never. Ever. Nipple stimulation also causes the release of oxytocin from the pituitary gland. It may initiate or enhance labor. Walking, gravity will apply pressure to that cervix, stimulating secretion of endogenous oxytocin. Mechanical dilators will ripen the cervix by stimulating the release of that endogenous prostaglandin. So you can use a balloon cath or a Foley inserted through the intracervical canal to ripen and dilate the cervix. It's going to be inflated above the cervical os with 30 to 50 milliliters of sterile water, and it results in pressure and stretching of the lower uterine segment and the cervix and the release of those prostaglandins. The Foley will fall out when it's approximately 3 centimeters dilated, which happens hopefully in about 8 to 12 hours. So that's a pretty natural process. So then there's hydroscopic dilators that are substances that will absorb fluid from the surrounding tissues and then enlarge. So it just basically swells up. Laminera tents, these are made from dried seaweed. It's inserted into the endocervix without rupture of membranes. As it absorbs the fluid, it expands and causes the dilation. It's usually left in place for 6 to 12 hours, and then a new dilator will be inserted if needed. Also, synthetic dilators such as Lamisil, it contains magnesium sulfate. It swells faster than natural and becomes larger with less discomfort. Amniotic membrane stripping or sweeping will cause the release of prostaglandins and oxytocin, which will hopefully induce labor. It involves the separation of membranes from the cervical wall and the lower uterine segment by inserting the finger into the internal cervical os and rotating it 360 degrees. It has been associated with a shorter pregnancy and decreased likelihood of going past 42 weeks, but it is extremely uncomfortable and can increase the risk of infection, rupture of membranes, bleeding, and precipitous labor and birth. An amniotomy is the artificial rupture of membranes. This is used to induce labor when the condition of the cervix is favorable, or to augment labor if progress begins to slow. Labor will usually begin within 12 hours of rupture. It if it does not stimulate the labor, it can resulting prolonged rupture can lead to an intraamniotic infection, which is never a good thing. Also, variable decels can occur as a result of cord compression when it is associated with a cord prolapse or decreased amniotic fluid. There's going to be some discomfort as the amnio hook or other instrument is inserted into the vagina and the cervix. However, the actual rupture of membranes is painless, but they're probably going to experience some discomfort. The presenting part should be engaged and well applied to the cervix prior to the procedure to prevent a cord prolapse. Also, mom needs to be free of an active infection of the genital tract and be HIV negative. So, immediately when an amniotomy is performed, you are going to assess the fetal heart rate. Why? Because as soon as that bag of water busts, all the fluids coming out, it can cause the cord to prolapse and actually come out of the cervix before the baby. It can also cause cord compression when that fluid is not there to basically cushion the baby against the cord. You're going to assess the color, odor, and consistency of the fluid, document the time of rupture. You're going to check the patient's temperature every 2 hours or more frequently. If it's 100.4 or higher, always notify the healthcare provider. And also, the nurse is not going to do this. Like, you as the nurse will never do this. There will be a healthcare provider that does this. So, just FYI. Now, chemical agents basically are... These are basically effective when they're used before induction to ripen the cervix. You have prostaglandin E1 and prostaglandin E2. So prostaglandin E1 is Cytotec or misoprostol. This is less expensive and more effective, but it is not FDA approved. It's usually used to treat peptic ulcers, administered intravaginally or orally, but the major adverse effect is hyperstimulation of the uterus. Also, it is contraindicated in women with prior uterine scars, such as a previous C-section, and it cannot be used in women who are attempting a VBAC or a vaginal birth after a cesarean. Now, the PGE is Cervidil or Prepidil or dinoprostone. This is more expensive, but the vaginal insert form can be more easily removed if there is an adverse reaction. Dinoprostone is the only FDA-approved medication for cervical ripening. Oxytocin is a hormone normally produced by the post-pituitary gland, which stimulates the uterine contractions and aids in milk letdown. Pitocin is synthetic oxytocin. It is used to induce or augment labor that is progressing slowly because of inadequate uterine contractions. So with low Bishop scores, cervical ripening is used before oxytocin is started. Now, you cannot start oxytocin until at least 4 hours after the last dose of misoprostol. Again, it can lead to fetal compromise and impaired oxygenation. The drug is closely monitored and titrated appropriately. Also, it has an anti-diuretic effect, which results in decreased urine flow, leading to water intoxication. So you're going to watch for headache and vomiting in moms that are on oxytocin because it can lead to water intoxication. So maternal hazards, uterine abruption, rupture, unnecessary C-section due to abnormal fetal heart rate and patterns. Also, postpartum hemorrhage and infection is increased in those who use oxytocin or Pitocin. Fetal hazards, so hypoxemia and acidemia, which result in late decels, and minimum or absent variability caused by decreased placental perfusion when the contractions are too frequent or prolonged. So the goal is to produce uterine contractions of normal intensity, duration, and frequency while using the lowest dose of medication possible. It is administered IV piggyback. It's titrated to achieve stable contractions every 2 to 3 minutes, lasting 40 to 60 seconds. The uterus usually responds to the medication within 3 to 5 minutes, and the half-life is approximately 10 to 12 minutes. It takes approximately 40 minutes to reach a steady state when those uterine contractions are effective. Non-invasive methods to augment labor: empty the bladder, ambulate and position changes, relaxation measures, nourishment, hydration. Hydrotherapy is usually attempted before invasive interventions. So vaginal birth after cesarean, it is a very controversial thing, but it happens. So the controversy is related to the risk of uterine rupture and hemorrhage. So mom has had a C-section, and she wants to have a vaginal delivery. Some healthcare providers will absolutely 1,000% do these, and some will absolutely not. The selection criteria that you can actually have this done: if the original C-section was done for a non-recurring problem such as fetal distress, prolapsed cord, breech presentation. Also, mom has to have a low transverse uterine incision, which I will show you in a further slide. There is an overall success rate of approximately 60 to 80%. The benefits of a VBAC: she will have a shorter hospital stay, less blood loss, fewer infections, and fewer thromboembolic events. However, the risks are uterine rupture, hysterectomy, operative injury, and neonatal morbidity. So the contraindications: absolutely will not do a VBAC if she has a prior classic uterine incision, that's an up and down incision, a prior transfundal uterine surgery or a myomectomy, if there is a uterine scar other than a low transverse cesarean scar, obesity, short maternal stature, macrosomia, if mom is over the age of 40, gestational diabetes, a contracted pelvis, and if there is inadequate staff or facility if an emergency cesarean birth in the event of a uterine rupture is required. Cannot use cervical ripening methods because this will increase the risk of uterine rupture. Spontaneous labor with a ripe cervix is more likely to result in a successful VBAC than induced or augmented with oxytocin or prostaglandins. If stimulation is necessary, oxytocin is the medication of choice because the risk of rupture is lower. So the patients who are most likely to have a successful VBAC are those who are under the age of 35, if the fetus weighs less than 4,000 grams, Now, the patient should be given information about a VBAC, encouraged to choose it as alternative to repeat section as long as no contraindications exist. There are VBAC support groups, there are prenatal classes that will help her to psychologically prepare for labor and vaginal birth. After being fully informed about the benefits and risks, more than 25% will choose a repeat section. As the nurse, you're going to encourage her to use breathing relaxation techniques, change positions often to promote that progress of labor. If the trial of labor does not result in a vaginal birth, the patient will need support and encouragement to express feelings about having to have another section, and it's important to not label it as a failed VBAC. VBAC rates have been decreasing with the current rate less than 10%. Many patients that are candidates for trial of labor and VBAC do not have access to healthcare providers and facilities that are able and willing to offer this. And many healthcare providers will not offer this because of liability concerns, clearly. But you're going to be watching for a uterine rupture, hemorrhage, or dysfunctional labor, and you have to obtain consent before this is completed. Intrauterine fetal demise is fetal death that occurs after 20 weeks gestation but before birth. There's numerous causes. It's devastating. It is associated with PTSD. It is associated with PTSD not only in the family but also staff. It's a very, very, very hard thing to watch, to have to go through as staff and as a patient. You're going to allow unlimited time with the stillborn after birth. You're going to encourage discussion of the loss. You're going to assist in funeral arrangements and be open and talking with the families about their loss and grief, and just provide as much support as you possibly can. Now, an umbilical cord prolapse is also an obstetric emergency. It's rare, but it occurs when the cord precedes the fetus outside of the body. It occurs in 1 out of 500 births. There is a 50% perinatal mortality rate, one of the most catastrophic events in the intrapartum period. So basically, there's either a partial or a total occlusion of the cord with rapid fetal deterioration. The cord is the infant's only lifeline, and if it's occluded, the perfusion deteriorates rapidly. The fetus will die if the cord compression is not relieved, and birth should be expedited ASAP. For the nurse, you're going to hopefully promptly recognize. Also, often the first sign is sudden fetal bradycardia or recurrent variable decelerations that are becoming progressively more severe. You will call for help immediately. You will not leave the room. You will do everything in your power to relieve that compression. You're going to place a sterile gloved hand into the vagina, holding the presenting part off of the umbilical cord until after delivery. You're going to change mom's position to modified Sims, Trendelenburg, or knee chest position, which will also help to relieve that cord pressure. Never attempt to replace the cord into the uterus because you can rupture it. You're going to monitor the fetal heart rate, maintain bed rest, administer oxygen, and prepare for probable and immediate C-section. So there you will literally may be in the bed with mom in Trendelenburg position with your hand in her vagina, holding that baby off the cord, the head off the cord, on your way to the OR, because like you got to get it done ASAP. A placental abruption is also an obstetric emergency. It involves premature separation of the placenta. It occurs in about 1% of all pregnancies. Risk factors: preeclampsia, gestational hypertension, seizures, if mom's over the age of 34, uterine rupture, trauma, smoking, cocaine use, coagulation defects, chorioamnionitis, premature rupture of membranes. Management is dependent on gestational age, the extent of hemorrhage, and if mom and fetus are oxygenated adequately. So you're going to make sure there is a prompt delivery of the fetus, a cesarean birth if the fetus is still alive, a vaginal birth if fetal demise, which we're hoping that's not going to happen. But it's basically the placenta will detach from the uterus, which is the baby's lifeline of oxygen. This is a picture of basically where it had abrupted, the placenta. Uterine rupture is also an obstetric emergency. The onset is marked by sudden fetal bradycardia. The uterus ruptures at the site of a previous scar into the abdominal cavity. Risk factors are previous uterine scars, prior C-section, prior rupture, trauma, if there's a prior invasive molar pregnancy, any congenital uterine anomalies. Crack cocaine use is a huge risk factor for uterine rupture. So you're going to see an onset of sudden fetal distress. Also, other signs can be acute and continuous abdominal pain with or without an epidural, vaginal bleeding, hematuria, irregular abdominal wall contour, loss of station in the fetal presenting part, and hypovolemic shock in the woman or the fetus or both. So you're going to prepare for an urgent C-section. The life-threatening nature of uterine rupture is underscored by the fact that maternal circulatory system delivers approximately 500 milliliters of blood to the term uterus every minute. Maternal death is a real possibility without quick treatment. It happens all the time. So forceps or vacuum-assisted birth, the decision to use these are based on the experience and personal preference of the healthcare provider. You're not going to see a lot of this anymore because you have a lot of healthcare providers that absolutely will not use these. Now, a forceps-assisted birth, the forceps is an instrument with two curved blades. It's used to assist in the birth of the fetal head. The cephalic-like curve of the forceps is similar to the shape of the head, with the pelvic curve to the blades conforming to the curve of the pelvic axis. The maternal indications, if she has had a prolonged second stage and need to shorten that second stage due to maternal reasons such as exhaustion, cardiopulmonary, or cardiovascular disease. Also, if for the fetal indications, if the birth of fetus it's for the birth of the fetus in distress, or in certain abnormal presentations, also arrest of rotation or extraction of head in the breech presentation. Certain conditions required to be successful: mom has to be fully dilated, bladder has to be empty, the presenting part should be engaged, vertex presentation desired clearly, membranes have to be ruptured, and the pelvic size has to be adequate for the fetal size. Traditionally, the blades are positioned by the healthcare provider, handles locked. Traction is usually applied during the contraction. Mom may or may not be instructed to push during the contractions. If there is a decrease in fetal heart rate, forceps are removed and then reapplied. With a vacuum-assisted birth, also called vacuum extraction, the birth involves the attachment of suction cup to a fetal head using negative pressure to assist in the birth of the head. It's generally not used before 34 weeks of gestation. It is, again, the prerequisites. You have to be fully dilated, membranes ruptured, head is engaged, vertex presentation, and no suspicion of cephalopelvic disproportion. Advantages over forceps: ease with which can be placed and need for less anesthesia. If it is unsuccessful, forceps assisted or C-section birth is performed, but the risk to the newborn: cephalohematoma, clearly, scalp lacerations, and subdural hematomas. Maternal risks are perineal, vaginal, or cervical lacerations and soft tissue hematomas. So a cesarean birth is the birth of a fetus through transabdominal incision of the uterus. It may be scheduled or planned, or it may be due to an emergency or an unplanned. It may have a negative effect on the patient's self-concept, so should focus on the birth rather than the operative procedure. The purpose is to preserve life or health of the mother and the fetus. May be the best choice for birth when there is evidence of maternal or fetal complications, but it still poses many, many threats to the health of mom and baby. The incidence is increasing. It's 33% of live births, partly due to the rise in the risk factors, malpractice concerns, and increase of maternal requests. As women age, the likelihood of having a C-section increases. May be related to biologic and medical factors, patient and healthcare provider concerns, and an increase of the rate of multi-fetal pregnancies. Type of nursing care may also influence rate. Approach that uses a one-to-one support and emphasizes ambulation, position changes, relaxation measures, oral fluids and nutrition, hydrotherapy, and non-pharmacologic pain relief supports physiologic progression of labor. It reduces the incidence of dystocia and also increases the likelihood of spontaneous vaginal birth. Once mom has a C-section, she's likely to have a repeat C-section. Actually, 92% will have a repeat C-section. VBAC rate is decreasing. So the reasons for a cesarean elective birth is fear of pain of childbirth and mistaken belief that surgery will prevent future problems with pelvic support, bladder and bowel incontinence, and sex dysfunction. Also, The ACOG recommends that a C-section on request not be done unless gestational age of 39 weeks has been accurately determined by ultrasound. The potential risks are longer hospital stays, increased risk of respiratory problems for baby because they're not mashed, and greater complications in subsequent pregnancies, such as uterine rupture, placental implantation problems, such as that. So the skin incisions, the type is usually determined by the urgency of the surgery and the presence of any prior skin incisions. So you have a vertical, so it's extending from near the umbilicus to the mons pubis. It's quicker to do, so it's used more for emergency C-sections, and it's also used for macrosomic infants and women who are obese. But it does leave a more noticeable scar, and the incision is weaker than the transverse. Now, the transverse is made across the lowest and narrowest part of the abdomen just below the pubic hairline. It's often called the bikini cut, most common, doesn't allow for extension of incision if needed, and does take more time to do. It is used for non-emergency C-sections, and that incision is strong. The low transverse is preferred, as it does not compromise the upper uterine segment. Also, that is the thinnest portion of the uterus. It requires only moderate dissections of the bladder, and it's easier to repair. There's also less likely risk to rupture during subsequent pregnancies. So that is basically your most common, and that's mainly what you want. Now, the classic is the vertical incision in the upper body of the uterus. You will never be able to have a VBAC if this incision is the type that you have. It is associated with higher incidence of blood loss, infection, and uterine rupture with subsequent pregnancies. And it's usually done due to a transverse lie, or if they are preterm breech presentation. Anesthesia is usually spinal, epidural, or general anesthesia. Epidural blocks are popular because patients want to be awake for and aware of the birth experience. The prenatal preparation, absolutely encourage her to go to childbirth classes. No patient can be guaranteed a vaginal birth, even if in good health. So all women are encouraged to know that they are always at risk for a C-section. Pre-op care, same as any other elective or emergency abdominal surgery. Anesthesia is assessed. If it's elective, mom has to be NPO for at least 8 hours. Labs are done 1 to 2 days prior. CBC type and cross match just in case. IV fluids are given. Informed consent is obtained. Foley catheter is given to keep the bladder empty. Pre-op meds usually include Bicitra, Reglan, Pepcid, and Zantac. This prevents aspiration pneumonia. Also, prophylactic antibiotics are given an hour before the surgery. That's to help prevent post-op infection. TED hose and sequential compression devices will be placed on the legs to prevent blood clots. Provide information about pre-op procedures, what she's going to feel, what will be done. Verbal communication is very important because silence can be frightening. She's going to have a covering. She's not going to be able to see what they're doing. So make sure that you are talking to her, making eye contact, using touch if culturally appropriate. Teaching them about post-op expectations and about pain relief, turning, leg exercises, coughing and deep breathing exercises, also abdominal splinting and incentive spirometry. If they have a scalp electrode, please, Jesus, make sure that you remove that from the baby's head before surgery. Yes. Father is usually assisted to get dressed and explain what he will need to do if he's going to be in the OR. So intraoperative care, it's usually done in either a traditional OR, mainly in an L&D OR. The L&D staff may be the circulating nurses. If the partner is in the room, they're going to be dressed appropriately also in all the surgical garb. Mom will be placed on a table with a wedge under her hip or a tilt table to the side, approximately 15 degrees. Legs will be strapped to the table to ensure proper positioning. The nurse from L&D or NICU usually comes to take care of the baby. A crib with resuscitation equipment is readied before surgery. After birth, if the infant's condition permits and the patient is awake, the baby can be placed skin to skin on mother or can be given to the partner to hold. The infant who is compromised is transported after initial stabilization to the nursery for observation and implementation of appropriate interventions. Oxytocin is given by the anesthetist, given an IV push dose to help the uterus contract, and it will decrease the probability of a postpartum hemorrhage. Immediate post-op care, basically ensuring adequate pain relief for the first 24 hours. Probably going to have epidural opioids by PCA or IVIM meds. Most common analgesics are opioids such as hydromorphone or dilaudid morphine, nalbuphine or Nubain, and NSAIDs such as ketorolac or Toradol, usually change to PO meds after 24 hours. Also, antiemetics are given such as Reglan, PRN, or around the clock for nausea. The palpation of the fundus with possible massage should be done after an analgesic is given because it's going to hurt regardless, but then you also have a surgical hole in your belly, so mashing around that is not going to feel good. So make sure you're giving her medication before massaging. She may be NPO or only sips and chips, so sips of clear fluid and crushed ice until bowel sounds will return, then advance to full liquids, then progress to diet as tolerated. IV fluids are usually continued until she is tolerating fluids orally, ensuring adequate rest, ensuring perineal care, breast care, routine hygienic care. Usually she can shower after the original dressing is removed on post-op day 1. Foley catheter is usually removed on post-op day 1. Ambulating her as soon as possible and several times a day after cath is removed. That's going to decrease the chance of a DVT. You're going to assess the fundus, lochia, and dressing and do vital signs according to agency protocol, usually every 4 hours and as needed. You're going to assess her breath sounds, bowel sounds, circulatory status of the lower extremities, and urinary and bowel elimination. Also, you're going to observe mom's emotional status and progress of attachment to the baby. Turn, cough, and deep breathe every 2 hours at least. Also doing leg exercises at the same time. Incentive spirometry if ordered. Safety, make sure you're keeping the side rails up, bed in low position, facilitating bonding, preventing constipation with a high fiber diet, keeping bladder empty to decrease the chance of a postpartum hemorrhage, and TED hose or SCDs until she's ambulating well. Is the following statement true or false? Psychological stress in the woman can contribute to dystocia. The answer is true. Emotions such as fear, anxiety, helplessness, being alone, and weariness can lead to psychological stress, indirectly causing dystocia. Which of the following assessment findings would lead the nurse to suspect an amniotic fluid embolism? The answer is respiratory distress. It should be suspected in any pregnant woman with an acute onset of respiratory distress and hypotension. True or false? Oxytocin is an important agent used to ripen the cervix for labor induction. False. It is used to induce or augment labor once the cervix is ripe. An amnio infusion is appropriate for a pregnant woman experiencing a prolonged second stage of labor. The answer is false. It is indicated for severe variable decelerations due to cord compression, oligohydramnios due to placental insufficiency, post-maturity or rupture of membranes, preterm labor, premature rupture of membranes, and thick meconium fluid.